In the past, we have assessed the risk of progression of prostate cancer based just on what we see on biopsy. So that's white light histology. And that has a certain amount of information that can somewhat accurately predict who's at risk for progression or not. But we have new tools now in our toolbox that makes it easy to more accurately predict who has cancer that needs to be treated and who doesn't. So one is MRI, which has been shown to focus our needles in the area most likely to harbor the highest risk cancer. But MRI is limited by what you can see. And there's great data that shows that MRI misses about 20% of high-grade cancers. And so that's not the answer in and of itself. We're in a biologic era now in all cancers, and we now have these other tools, these gene expression profile tools that I spoke about, that we can assess on biopsy that can tell us things that a pathologist can't see under white light histology. And one of the studies I reviewed was a new one that showed that you can see genomic and transcriptomic changes in the benign tissue that's adjacent to cancer. And that's really fascinating. What that suggests is that to get a clear read on risk of cancer and cancer aggressiveness, the needle doesn't necessarily have to strike the highest grade cancer. You can get a signal from the field that's around it. And so what I attempted to do was to put that in context and understand now how we can shift the diagnostic curve to the left and start making clinical decisions based on what can be measured at the molecular level rather than at the histologic level. They're intended to be used side by side. So there is a lot of information that histology can give us. So for example, if you have a predominantly pattern 4, Gleason's pattern 4 tumor or higher, you probably don't need a gene expression profile to tell you that that patient needs to be treated. Or if there's a cribriform histology or intraductal histology present, those are pretty good indicators that patients need to be treated. But lots and lots of the prostate biopsies that we do show low-grade cancer, Gleason 6 cancer or Gleason 3+4 cancer. And we know that most of them can be watched, but there are a few that have the biologic potential to progress and either need to be treated immediately or those patients need to be monitored a little more closely. So again, it's meant to be used side by side to histology and in complement with MRI. They're not mutually exclusive technologies.